Ladies and gentlemen, good afternoon. What we have here is a case of a 47-year-old married man residing in Manila who works as a cruise line staff with complaints of diarrhea and generalized body weakness of 4 days duration. Medical history revealed moderate dehydration, secondary to AGE, presenting with 4-day history of watery, non-bloody stools with the following manifestations, which later led to the progression of weakness associated with decreased urine output. To further substantiate the case, here are the pertinent positives. And as per assessment, vital signs yielded the following results. Generally, patient displayed coherence but with weak-looking disposition, and with the following physical examination record. Furthermore, this is accompanied with the 3 salient features we have narrowed down. First, loose stool episodes, vomiting, and abdominal pain point us to note that patient is diarrhea, which we could further classify as acute since it persists for less than 2 weeks duration. And according to the algorithm for the management of diarrhea, we have to note that the clinical manifestations may fall likely on non-infectious, brought about by these factors. The medications is ruled out because of the absence of treatment regimen that can trigger diarrhea. Patient presented with no alternating or change in bowel habits, sign of weight loss, intermittent bleeding, and the old age predilection is not applicable. Thus, IBD, possible colonic mass, and diverticulitis ruled out as well. Or also, it may be likely infectious. So without the changes in bowel habits nor defecation problems, a non-infectious case may be unlikely. Therefore, locking it as infectious, it will subsequently be classified either inflammatory or non-inflammatory. So classifying it as non-inflammatory, these organisms were considered due to the following consistent findings with our patient's case. As per CDC, 90% of cruise ship GI illness outbreaks are due to norovirus infection with a febrile presentation. Patients of febrile, travel history, and occupation are suggestive of these preformed toxin-forming organisms. Multiple sexual partners, travel history, and PE may rule in cryptosporidium. And finally, identified as most probable cause of traveler's diarrhea is E. coli, which forms enterotoxin and causes non-bloody diarrhea. Moving on to the second salient feature, all these symptoms you can see there are suggestive that the patient was having dehydration. And as to the adult dehydration guideline with primary options for acute care, patient was presenting severe dehydration with those criteria being met. And thirdly, hyperemic tonsils, bilateral cervical lymphadenopathy, and dysphagia to solids would tell us a characterization of possible pharyngitis, which could be a symptom of URTI. And consequently, if combined with atypical GI symptoms, it could suggest disseminated TB or immunocompromised state, probably due to acute retroviral syndrome. So taking all these 3 into account leads us to question, what possible complications can the patient have at this point? So to further explain the disease development, here's what transpired in the course of patient's hospital stay. Day 1 there, you can see the features. And with PCR negative and dengue blood positive to both immunoglobulins M and G, we can summarize this in 3 points. Patient could have had previous infection, there was cross-reactivity, and compared with dengue blood, PCR yields more specificity, hence, there is unreasonable doubt why it generated a negative result. Day 2 and 3 there of hospital stay, patient became hypotensive with decreasing blood count despite transfusions and clinical management, continuous bleeding presentations, which soon resulted to an early demise as a case of dengue hemorrhagic shock. Now, these are the laboratory results in the course of patient's hospital stay. And as shown in the results, the patient had azotemia and oliguria, which are signs of ARF. Pre-renal azotemia caused by acute diarrhea that led to severe dehydration, which basically decreased the renal plasma flow, causing ischemia of the renal tubule, hence causing injury. And to come up with a specific etiology for this, we compared the following differentials you can see there. In contrast with ITP and TTP, hemolytic uremic syndrome is ruled in due to its high association with infectious diarrhea, the presentation of its characteristic triad, and accompanied by an absence of fever. So for our considerations, given the acute nature of the disease entity, which progressed to an expedited worsening of GIT symptoms, with possible pharyngitis and history of travel, and multiple sexual partners, we considered that the patient there was in an immunocompromised state. And on the other hand, we also were not able to exclude the possibility of disseminated TB because of bilateral cervical lymphadenopathy and GI symptoms present in the case, which could be atypical presentations. And lastly, It is known that post-diarrheal infections commonly lead or present as HUS, hence secondary to infectious diarrhea, which makes our last consideration. So in summary, the patient's infectious diarrhea led to severe dehydration, which spiraled down into the eventual development of acute renal failure. The notable increase in creatinine and BUN, blood components, and coagulation tests, together with the patient's aforementioned risk factors, all support acute kidney injury. And this can be described by using 2 points: by toxins directly injuring the endothelium, which subsequently result into hemolysis, bleeding, and widespread coagulation, or because of severe dehydration itself. Both may give a thrombotic effect that forms obstructions, which impairs kidney function. And at this point, we can say that the patient has acquired ARF due to hemolytic uremic syndrome secondary to infectious diarrhea leading to DIC. But on top of all these, we also feel that it is important to note that the patient showed signs of URTI, of which 2 were identified that could also manifest GI symptoms, disseminated TB, and immunocompromised state due to ARS, and have expedited the course of the disease progression. So hence, with all those considerations and findings, our team's final diagnosis would be disseminated intravascular coagulation, secondary to hemolytic uremic syndrome, secondary to infectious diarrhea, cannot totally rule out disseminated TB, to consider immunocompromised host. Thank you.
According to the journals that we have read, yes, it is mostly commonly found in children, but it's also increasingly found in adults. So we have considered this given that there are already published studies confirming that HUS, secondary to infectious diarrhea, already exists in adults.
Yeah. So why not consider acquired type of TTP rather than HUS?
The characteristic features of PTP includes a pentad, which includes fever and neurological symptoms, which the patient did not manifest. Why we have arrived at HUS, it's because we consider that the patient might be immunocompromised, thus manifesting those symptoms just like a child. So hemolytic uremic syndrome is common to the child, and those symptoms, since the patient is immunocompromised, may be manifesting them.
Do we need the 4 symptoms, or do we need to fulfill the pentad for TTP to be able to diagnose?
Not exactly, Doc. But according to published studies as of now, so the 2 syndromes or the 2 conditions, TTP and HUS, now manifest interchangeable manifestations. Like these days, HUS sometimes have been established to manifest neurologic symptoms, while the TTP sometimes have been established to manifest rather renal failure cases. So in this case, there's no need to establish or there's no need to follow all those pentad. But then one distinguishing feature between the 2 would be to make sure that there is significant difference in the Adams TRS 13 level, which would eventually distinguish one from the other.
Can you rule out a lymphoma in this patient? For example, a hematologic malignancy like a lymphoma, which can actually present the same way, mimic the presentation of the patient. And what features go against a lymphoma and go for and why did you choose, for example, why would you choose TB over a lymphoma? Why would you choose TB over a lymphoma?
To differentiate, to answer the first question, why we didn't consider lymphoma, but instead we considered TB first, because we all know that malignancies they manifest with first weight loss, significant weight loss in the patient, which unfortunately wasn't able to be substantiated in the history. They just said that there was no malignancy, it was part of the pertinent negative. At the same time, there was no significant weight loss. And secondly, if it were a hematologic disease, the patient would have had complaints like tenderness in in the splenic area, or he can also have just said that he had been experiencing progressive weakness for months on end, because we know that the manifestations of lymphoma, they do not occur acutely, or they just have these representations in a very short period of time. He could have said in the history that before the diarrhea happened, he had a progressive weakness, which would actually bring the patient to consultation instead of diarrhea. And also we consider TB because of the apparent URTI representations, like which we had highlighted as pharyngitis. At the same time, we also considered this because there are also reported cases of disseminated TB in the GIT. So we chose that over cancer or other hematologic malignancies.
But shouldn't TB also present with weight loss, fever, chronic symptoms, everything that Shirley stated? Shouldn't TB also present with those findings? So, do you think, can you think of something else that would point more to TB strongly than consider a hematologic condition?
We would like also to highlight one more thing about the history of the patient is the travel and also his 7-pack year history of smoking, which would make him more vulnerable not only to exposure but also to the condition of his respiratory system. So I think that also answers the question.
So, taking everything into account, you proceeded to choosing TB.
Yes, please.
Okay, thank you for the questions. Thank you to our 8th presenter. Yes, thank you.